Thank you very much. It's really a great pleasure to be there for this educational webinar session. I am Michel Ducret. I am the head of GI Oncology Unit here in Gustave Roussy Cancer Center in France. And I am very happy to be there with two people that are working in this field of hepatocellular carcinoma. First, and he will be the first speaker. It's Dr. Timon Vandamme, who is a medical oncologist working in the digestive and neuroendocrine oncology ward at the University Hospital of Antwerp in Belgium. And the other one is Associate Professor Sheng-Gun Yu, who is also a medical oncologist in the Department of Oncology at Asan Medical Center in Seoul, South Korea. What we will discuss, and we will focus specifically on clinical takeaways, and we will see this slide again at the end of this moment, because it's very important for us to give you information, especially on the substantial part of advanced hepatocellular carcinoma patients who are not eligible for IO in first line. And we know that for these patients, TKIs remain the recommended treatment, and we will see the results of the use of this drug in these patients. Something that is very important also is the fact that even if IO is the standard of care for a majority of patients at this time, we know that after a period of time, these patients will progress, and there is probably the right moment to move from first line to second line treatment. And this is something that will be discussed too. And at the end, we will look on the multiple second line treatment options, because as you know, there are now so many options of treatment that are present for the treatment of HCC, that it was very simple 10 years ago, and now I would say it's a little bit more complicated. So first of all, I am happy to present again Dr. Timon Vandamme, who will review the outcomes in hepatocellular carcinoma with first-line immunotherapy, and focus especially his talk on when is the right time to switch.
Thank you, Michel, for the kind introduction. I'm very honored to be here and to be able to discuss with you today this interesting topic. So what we know is that liver cancer is the sixth most common cancer worldwide. Incidence is about 5% of all new cancers cases in 2018. And as you can see, it's firmly in the top 10 of the most common cancers worldwide. And when we look at liver cancer, we know that HCC is responsible for about 90% of all liver cancer. So HCC is global and important clinical problem. So when we look at the incidence of liver cancer across the world, we do see that there is the highest incidence in low and middle income countries, with a very high incidence in Eastern Asia and a somewhat lower incidence in, for instance, Western Europe. We know that 75% of all the patients are for low and middle income countries. And liver cancer is actually more common in men than in women, with it being the fifth most common cancer in men, while it's the ninth most common cancer in women, respectively. Despite this difference, even in women, it is still in the top 10 of the most common cancers. But this aside, we do know that men have a threefold higher risk of developing liver cancer than women. And what is actually one of the most common causes of hepatocellular carcinoma is the presence of cirrhosis. We know that 85% of the HCC is appearing in cirrhotic livers. There is still 15% of the HCCs that there is appearing in non-cirrhotic livers. That disease does seem to be slightly different than the HCC occurring in cirrhotic cancer, cirrhotic livers. But it's important to know that this cirrhosis is a very important predisposing factor, and we know that this is an evolution from healthy liver through to cirrhosis by chronic liver damage. This chronic liver damage is a consequence of the chronic liver inflammation, and then it will be followed by diffuse hepatic fibrosis, which is this so-called cirrhosis, whereby normal hepatic architecture is replaced by these regenerative hepatic nodules, and finally liver failure. There are many causes for cirrhosis, one of the most common ones being viral causes for cirrhosis, while lifestyle factors are also very important, including heavy alcohol consumption, with where we know that 15 to 20% of all heavy alcohol drinkers will develop cirrhosis over time. We do see that there is a difference in the occurrence of cirrhosis worldwide, with a range going from 8.5 per 100,000 people in Oceania to 60 in 100,000 people in Central Asia. And we know that this cirrhosis is really an end stage of liver disease, and that is really a fertile ground for HCC to appear. So we start with a polling question. What are the recommended treatment options for advanced HCC patients in first line according to the Barcelona Liver Clinic guidelines? Option A is sorafenib and lenvatinib. Option B is sorafenib, lenvatinib, and durvalumab. Option C is atezolizumab plus bevacizumab or durvalumab plus tremelimumab. Option D is atezolizumab plus bevacizumab, durvalumab plus tremelimumab, or if not feasible, sorafenib, lenvatinib, or durvalumab. E could be all of the above without a specific order, and F is always right, I am not sure. So we'll give you some time to now answer this question. Please participate so we know what you are thinking about this. Okay, the polling is now closed. We will go to the results. So what we do see is that about 30% of all people say that sorafenib and lenvatinib is the first option, but the majority of people go for option D, with 60% of the patients, of the participants saying that the IO combinations are first line option of choice. So when we look at the BCLC updated treatment algorithm, and this is the last treatment algorithm, we know very well that HCC is divided in different stages, going from early stage, which is stage 0 to 0 and A, to intermediate stage B, advanced stage C, and then terminal stage D. I think we will now focus mainly on the stages where systemic treatment is of importance, which is the intermediate stage B, multinodular disease with preserved liver function and a performance status of 0, and the advanced stage where there's a portal invasion with or without extra hepatic spread, a preserved liver function, and a performance status 1 to 2. And there, systemic treatment has a firm role according to the BCLC guidelines. And when we look in more detail to this systemic treatment, we will see there that the recommendations currently are to use atezolizumab, bevacizumab, durvalumab, or durvalumab, tremelimumab in first line. If sorafenib, if not feasible, then sorafenib or lenvatinib or durvalumab are equally good options. Concerning second and third line, there are also some recommendations which will be also discussed more in detail later. So why is this IO the new standard of care in HCC? This is based upon two important trials. The first trial is the atezolizumab plus bevacizumab trial, which is studied in the IMbrave 150 trial. Atezolizumab is an anti-PD-L1 antibody, and bevacizumab is a VEGF-I inhibitor. And this combination was studied in locally advanced or metastatic and unresectable HCC that were not priorly systemically treated, that had more than one untreated lesions with a good performance status and also an adequate liver and other organ function. The patients were randomized in a 1-to-1 manner between atezolizumab plus bevacizumab versus sorafenib, the previous standard of care. There were, of course, some important exclusion criteria. One of those I would like to highlight is the presence of autoimmune disease or liver transplant, and the incompletely treated high-risk variations were two important exclusion criteria for this trial. Primary endpoints were overall survival and progression-free survival. And so what we did see is that this was a statistically significant positive trial with a median OS of increase of 6 months in the intervention arm with atezolizumab bevacizumab when compared to sorafenib. And we do see that there is actually quite a nice overall survival that is reached in the atezo plus bev arm of almost 20 months, which is, of course, I think quite good in this hard-to-treat population. What is interesting was that in this trial also the patients with portal vein invasion, the so-called VP4 group, were included. And there we also see a significant effect of this immunotherapy. So we also have another combination that's available for our patients in first line, which is the combination durvalumab plus tremelimumab, which is a combination of an anti-PD-L1 antibody immunotherapy in combination with the anti-CTLA-4 immunotherapy. So this is a dual IO strategy, which was tested in the Himalaya trial, where they looked at unresectable HCC without parasystemic therapy, BCLC stage B or C, child class A, and also a good performance status. And those patients were actually randomized in a 1-to-1-to-1 fashion with 4 initial arms that were included: a durvalumab monotherapy arm, a durvalumab tremelimumab arm, regimen 1, and durvalumab tremelimumab regimen 2, and a sorafenib arm. In the end, they skipped one of the regimens of durvalumab tremelimumab, and they ended up with a so-called STRIDE regimen, which is a combination of a single dose of tremelimumab of 300 milligrams followed by durvalumab each month. So this is a dual IO strategy with only one time the CTLA-4 that is induced, that is given. The primary endpoint of this trial was overall survival, and there were, of course, the known key secondary endpoints, including the time to progression and progression-free survival, overall response rate, disease control rates, and duration of response, safety, and tolerability. And on the next slide, we will see the results of this trial. And this was also a positive trial showing a significant benefit in overall survival versus sorafenib, where the median OS in the STRIDE arm was 16.4 compared to the 13.8 in the sorafenib arm. And I think this is, once again, good news for a patient that the STRIDE regimen is available. What is, I think, of importance to note is that there is a relatively long tail of patients that have a survival beyond 3 years, where you see that after 3 years in the intervention arm with STRIDE, still 30% of the patients were alive. And this is something that we see in many IO trials, that there is actually a prolonged duration of response. Of course, the question is then, we have now 2 very potent options in first line when it comes to IO. And the question is now, when is it time to switch to second line therapy? And when could we consider re-challenging our patients with IO? And I think we really have to focus on the safety of these new IO combinations. So we know with immunotherapy that there are immune-related adverse events that are present. And I think these immune-related adverse events can happen anywhere in the body at any time. So that's really somewhat of a black box for us as clinicians, that we really have, when we treat patients with IO, that we really have to be very careful to always ask about complaints and be wary that sometimes relatively uncommon complaints can be the first sign of an underlying immune-related adverse events. So we always have to ask 10 questions when we talk about immune-related adverse events. Is first, why do they occur? How are they generally treated? When do they occur? Why do they occur in some patients and not others? Are they associated with the efficacy of immune checkpoint blockade? Does immunosuppression to treat such adverse events reduce the anti-tumor efficacy of the treatment? Are there unintended effects of immunosuppression that treat adverse events? Is it safe to restart treatment after a major adverse event? Is it necessary to restart treatment after resolution of an adverse event? And is it safe to treat patients at a potentially increased risk for such adverse events? These 10 questions are very important and should be asked continuously when treating patients with IO. Not for all of these questions we have a solid answer yet, but we do have some things to take into account. So the immune-related adverse events can happen through the body, as said before. They happen in the neurologic system, in the eyes, in the endocrine system, cardiovascular, kidney, musculoskeletal system, the skin, liver, the gastrointestinal tract, and the lungs. What is interesting is that there is actually a delay in the occurrence of this immunity therapy-related toxicity. So we know that patients don't immediately often don't immediately have their immunotherapy-related event, but that is often a late event. And there is actually also a window where this changes. So the first immuno-related event that we see is rash or pruritus, while, for instance, diarrhea and colitis happen somewhat more later, only after mainly about 2 months after start of treatment. Hypophysitis, for instance, can happen far later, even months after treatment has started, and sometimes even after discontinuation of treatment. So I will really focus now on those toxicity in the gastrointestinal tract. So before we go into detail about immunotherapy-related adverse events, I would like to highlight one of the peculiarities of the IMbrave 150 trial, which is the bleeding risk associated with the treatment with bevacizumab. So within the inclusion criteria of the trial, it was necessary to have gastroscopy before the start of treatment to see if there were varices present. And if these varices were present, they should be treated according to standard of care in the local centers before start of treatment. But even despite this rather intensive, let's say, follow-up before the start of treatment, we did see that in 25% of all patients there was a bleeding-related event, and even sometimes quite severely. And we did see some grade 5 toxicity, so some patients that unfortunately died due to very intensive bleeding events. So the polling question now is, what is the most common immune-related adverse event in HCC patients? First, diarrhea and colitis. B, infusion-related reactions. C, hepatic toxicity. Or D, other. I think the vast majority says that diarrhea and colitis are the most common toxicity of immunotherapy. We do see indeed that these gastrointestinal and hepatic immune-related adverse are important. I will now focus on the left-hand side of the screen, mainly on the atezolizumab and durvalumab treatment arms, where we can see that this in PD-L1, actually the presence of colitis and hepatic problems is relatively limited, and only about 1 to 2% of all patients, about 15% of the patients there is diarrhea appearing. However, this true colitis zone is present in less than 1% of all patients, and the same goes for hepatic toxicity, especially if you look at really high-grade toxicity. Same goes for durvalumab. And then what is, I think, an important way to look at this toxicity is the need for the use of corticosteroids to treat immune-related events. So what you do see in the STRIDE trial is that about 20% of all included patients that received STRIDE regimen in the Himalaya trial needed corticosteroids to control immune-related adverse events, while in the IMbrave this was about 10%, which is something we know from other trials. In summary, the adverse events of atezolizumab with bevacizumab, if you look at the overall presence of adverse events and grade 3-4 adverse events, we do see that in general, the toxicity profile of atezolizumab with bevacizumab seems to be more favorable than sorafenib, with definitely less diarrhea and less pulmonary erythema. What is important to know is that actually in most cases, you're able to re-challenge the patients after resolution of the IC-induced enterocolitis or hepatotoxicity. What is important is that when you have this kind of toxicity, that you start corticosteroids rapidly. If there is no good or swift release, recuperation, especially when talking about enterocolitis, you should really switch swiftly to infliximab or vedolizumab. And what is also important is that you have a very slow tapering. So it's important to taper this corticosteroids both in enterocolitis and in hepatotoxicity over the course of multiple weeks, sometimes 4 to 8 weeks. But after tapering, in most cases, you're able to restart immunotherapy. And that brings us to progression. One is the time to switch to second-line therapy. And we will go for another polling question. How would you measure progression in HCC patients? Would you use the CHOI criteria, the EASL criteria, RESIST, modified RESIST, or E? I am not sure. Most people go for RESIST. And I think what is interesting to see here is is an illustration of the difference between resist and modified resist. Here you have a patient before the start of treatment and then after immunotherapy. The white bar demonstrates the classical resist criteria, where you see actually an increase of size of the lesion, while the brown bar is the modified resist criteria, where you only measure the still active disease. And that's quite a big difference. And there you actually see stable disease to even some response. And I think that's really an important one to take into account, that actually modified resist is probably more powerful to discriminate between responders and non-responders when it comes to immunotherapy than the resist criteria, because there is some pseudoprogression there. I think, especially if you look at on the right-hand side of the screen, you see there that resist, that often patients that are scored as progressive disease by resist criteria actually turns out to have stable disease when using modified resist. And I think that's an important one to take into account when treating patients with IO and when deciding when to switch. So in conclusion, when reviewing the outcomes in HCC with first-line IO, when is the right time to switch? I think we all see in our daily practice that HCC is an increasing global healthcare challenge. Secondly, IO is an effective standard of care first-line treatment in advanced HCC with rare but potentially dangerous side effects. Switching to second-line therapy after IO first-line should be considered in case of toxicity or disease progression. And measuring disease progression in HCC can be challenging, as there are several methods with different evaluation criteria, and it does seem that mRECIST is a powerful tool to discriminate between responders and non-responders. And with that, I would like to thank you and hand over the floor to Michel.
Thank you very much, Timon. First of all, I have one question for you. Do you think that it is more complicated to evaluate the response and progression when we are combining an antigenic agent such as bevacizumab and atezo, or two immune therapy such as with durvalumab? Very short answer.
Yeah, I think both are equally difficult. I think the Beva does change the vasculature of the tumor, and that can be sometimes more difficult to interpret. However, with the dual IO, you have, I think, more risk for pseudoprogression than only with a single PD-L1.
And there are two questions, or two or three questions in the chat about the role, but it was not completely your topic. The role of SBRT for the treatment of hepatocellular carcinoma, and even the role of combination of SBRT plus sorafenib, because there is a trial evaluating this combination.
I think SBRT is in a way a little bit a new kid on the block. When it comes to HCC, a long time it was not commonly used radiotherapy in HCC treatment. Now recent trials did show, actually even in patients with advanced HCC, benefit of using SBRT. However, those trials were not really comparing SBRT to the new standard of care IO treatments. They looked to our combination with sorafenib. So I think what the role of SBRT is, especially in the new landscape of IO treatment, is still to be seen. And I think we have to await further studies.
You didn't speak about too much about endocrine dysfunction, and especially about thyroid dysfunction related to immune therapy. Do you consider that this is a problem or not?
Yeah, honestly, I must say in my clinical practice, the thyroid dysfunction is very common in immunotherapy-related adverse event. It happens in almost all patients, but it's also a very easily manageable toxicity. So they go to a hyperthyroid first, and then they go to a hypothyroid phase. Most patients don't become symptomatic during the hyperthyroid phase, so you don't really have to do something. And when they become hyperthyroid, you have to replace. So you just have to start L-tyrosine. We almost never need to stop our immunotherapy treatments due to thyroid-related problems.